Thank you for coming. I'm going to be presenting today on vestibular hypofunction in a collegiate golfer. This was a patient that I saw in Jacksonville, Florida at the Brooks Balance Center. So pretty much my entire caseload was vestibular patients. So the purpose of this presentation is to present an evidence-based case study of physical therapy management of a patient with vestibular dysfunction using the ICF model. Also, this provides a good opportunity for personal and professional growth, and it helps to facilitate a learning process amongst a peer group. So basically, the ICF model, which most of you are hopefully familiar with, it's a biopsychosocial model. So we're going to be looking at some of the medical aspects as well as psychosocial aspects, and I will be kind of filling this in as we go along. So the referral for this patient came in on October 24th, 2016. So this was back in the fall semester. It came from the Jacksonville Hearing and Balance Institute, which is an otolaryngologist office, easier known as an ENT office. They were right next door to us. We had a very good working relationship with them. The referral asked for vestibular rehab, eval, and treat. The diagnosis code provided was other abnormalities of gait and mobility. Also in the referral was a nice hefty little packet of diagnostic tests that were run. So I'm going to go through some of those with you guys. The first diagnostic test that was performed in the ENT office, they actually do some posturography over there. So they did an SOT, and you can see there are a few things highlighted in red. That's pretty much throughout this presentation. Anytime you see something in red, it's indicating that it was some type of abnormal or atypical finding. The things that are in black were considered to be normal. So this patient failed conditions 1 and 2, which is a little bit atypical. These conditions, you're just standing with your eyes open and standing with your eyes closed. She then was able to pass the rest of the conditions and had a composite score that was within normal limits. Her center of gravity was noted to be abnormal and posterior, but as far as strategy analysis, motor control test, and adaptation testing, these were all normal. Another test or sequence of tests that they do over there is BNG testing. So as you can see in the picture here, they use goggles, which will actually get a video recording of the eye to do their oculomotor exam. So this is a very sensitive test. It actually records and picks up any movements. The only thing that was abnormal with this testing was during optokinetics. She had an abnormal velocity gain on the right. She did not have any spontaneous nystagmus. They did do positional testing over there. It was negative. No gaze of open nystagmus, and caloric testing was also normal. So more information they gave us. They also did what's called a vent. So there's actually a reflex that when you hear a loud noise, it will create a contraction of your sternocleidomastoid. So they hook up EMG to your SCM, and they measure that. For this patient, when she had her head turned to the right during the left vent testing, she just had a subjective reported dizziness, so they included that in their report. And she also had an abnormally large vent on the left. And so finally, the last thing they do is rotational chair testing. So you go into this little pod, it's completely dark, you're wearing the goggles, and they basically spin you around and make you do all kinds of things. So again, this is more sensitive than if we had done like head shaking tests, things like that, like with our hands. They're able to pick up on these things better because they have this equipment. But the only thing that was abnormal for her here was during the velocity step test, she had a time constant that was reduced to the per rotary right. Subjective visual vertical is also here. You have no frame of reference, and they give you a line, and you just have to try and put the line perfectly up and down. She was fine with that as well. So that was all the testing that they did over there. That was all the information that we got. But they also said that they did order a CT scan to look for any abnormalities within that inner ear, and they also had a brain MRI that was scheduled for her. Both of those ended up coming back as being normal later on in our treatment. And then as far as medication, she was prescribed meclizine to take as needed. However, she was not taking it at all. And I think she had previously been taking Zyrtec herself, so those were all her medications. So going back to the ICF model, just from all the information that we got there, her health condition is a non-specific vestibular dysfunction because there was nothing really that stood out in the testing. There was no patterns, there was no real big sign. It was just kind of little things here and there that were just a little bit off. But fortunately, in physical therapy, we treat based off of impairments. So it really wasn't too much of a concern there that we didn't have a true medical condition. So now as far as the intake forms, these are things we have her fill out before she comes in. So we've got some information there. She's a 20-year-old female. She had an $85 copay for each visit. Medical surgical history, she listed broken bones, dizziness, loss of balance, headaches, and vision problems. When asked to describe the problem for which you seek therapy, she said vertigo, and stated that the onset was 3 years ago. Also from these intake forms, we gathered that she lives alone in a college dorm. She is a full-time student. She's a freshman in college. She denied any smoking or alcohol use, and she rated her current health habits as good. So nutrition, exercise, and sleep, trying to kind of cover our bases in terms of looking for red flags, those things, and she was a generally healthy young lady. You're probably familiar with this as well as a pain diagram. For us, we used it as a symptom diagram. So she circled the front and back of the head, stated that her symptoms at worst are a 10 out of 10, and at best are a 0. It's a pretty big difference there. So now at this point, we finally get the patient back into our eval room to do our own subjective history. She reports that her chief complaint is a sense of dizziness and that the environment is tilting. She said that she's had these symptoms intermittently, she thinks for about 3 years, but it wasn't really a bother until she started college 3 months ago. So since then, she's pretty much been getting these symptoms like on the daily, so it's a big enough issue for her to seek out help. So now for activity limitations, ambulation was causing her to be a little symptomatic, but only when she was negotiating uneven surfaces, such as going up and down hills or grassy inclines when she was on the golf course. Also gave her the patient-specific functional scale so that she could kind of rate her ability, and she rated it as a 5 out of 10. So 10 out of 10 would be, I can do this with no problem. So she rated that as a 5. As far as community activities, she said that she was symptomatic in busy environments, such as grocery stores, department stores, church, and any type of large crowd that she was in. She also rated this as a 5 out of 10 on the PSFS. As far as school, she was symptomatic when scrolling on the computer and when looking back and forth from the whiteboard down to her computer screen. She also rated this as a 5 out of 10 on the PSFS. As far as golf, she stated that she was specifically symptomatic when she would kind of bend forward to tee up or when she was practicing at the driving range as well as putting. Unfortunately, I did not get a PSFS score for this one. Looking back in hindsight, that's definitely something that I should have asked at some point along her care because golf was definitely important to her. So I do wish that we had that number, but you know. So now to the objective portion, we started doing our actual exam. So with the cervical screen, her active range of motion, everything was normal in all planes. She did not have any history of cervical pain, no neck or head injuries, and she had never been in a car accident. So everything seemed A-okay there. So now as far as static balance, remember anything in red is considered what would be abnormal. So when we had her stand in left sharpened Romberg, so that's heel to toe with the left foot in the back, with her eyes closed, she could only hold that for 14 seconds. And this is challenging, but for someone that is 20 years old and a college athlete, it's definitely abnormal to not be able to hold that for longer than 14 seconds. And the same was true for this foam that I have pictured there. Refer to it as a deep foam because it's a lot squishier than that typical blue Air-X foam that are used in a lot of clinics. She was also only able to hold that for 11 seconds with a narrow base of support and eyes closed. So again, something is a little off there, so that she should be able to complete that. As far as dynamic balance, it was kind of all over the place as well. She is a college athlete, so you're not going to pick up on anything with just regular walking. So we had her walk with eyes closed, and when she did that, she held her arms in high guard. She had a lot of staggering, and she also had a lot of excessive trunk motion. So she did a lot of like side to side bending, like very just excessive. She also drifted from midline. So with her eyes closed, she didn't walk in a straight line. She veered off to the right, which is typical for someone with a vestibular dysfunction. When walking in tandem, so heel to toe, she also held her gaze down. She had all of this extra motion here, and we tried to take an objective measure of that. So over 10 feet, she had 3 losses of balance. And going backward was the same thing, except she actually had 6 losses of balance while going backward over 10 feet. So again, very atypical for someone just of her age and health. So we looked at VOR and DBA. So we start with getting a just baseline of her dizziness. So she said that it was at 0. We then had her perform horizontal VOR for 30 seconds. After performing that, she reported that her dizziness increased to a 3. We then let that calm back down to a 0, back to baseline, and tested vertical, stated that increased to a 1, back to baseline, then did head tilts. It's the same concept as VOR, but it's just with your head going side to side, and that increased her symptoms as well. As far as just static visual acuity, so just her vision, she did not have 20/20, she had 20/32, so it wasn't great. We mentioned that to her, do you have glasses? Have you ever seen someone? She did not have glasses, she was not really interested in getting glasses. As far as her dynamic visual acuity, so reading the eye chart again, but with the head moving side to side, her vision was 21/60. So that's a 7-line difference. And what would be considered normal would be a 2-line difference. So that's definitely atypical. As far as outcome measures, we did do a DGI. And looking back again, I think this was maybe a little bit low level for her. It's going to be likely to kind of get the ceiling effect. She didn't score perfect on it though. She got a 22 out of 24 because when asked to walk with head movement, she deviated in her gait a little bit. She didn't lose her balance, but it just caused her to have a bit of a perturbation, which lost her those points. Her gait speed was fine, and on the DHI, she scored a 44 out of 100, which would make her in the category of moderate for the perception of handicap. So back to the ICF model. Now that we've done our whole evaluation and assessment, try to piece some of this together. So the impairments that we found were decreased gaze stabilization, dizziness with ADLs, poor static and dynamic balance, and poor postural control. Her activities are walking, specifically like on the golf course, that type of thing, grocery shopping, or any of the environments that she would have to be in with those busy environments, as well as scrolling on her phone, studying, driving, like as in golf, driving, putting, and teeing up. Participation for her, the most important things is that she needs to be able to be a student. She needs to be a good teammate. She needs to be able to perform as a golfer. So environmental factors to consider would be the classroom, church, again, any of those settings that were big, busy environments, and then, of course, golf courses. So personal factors for her, she is young and healthy. That $85 copay I felt was important to include because that can definitely affect your treatment, as I had seen in other clinics before. And then travel distance. So we were the only vestibular specialty clinic in Northeast Florida. So she was actually driving over an hour from Georgia to get to our treatment sessions. So after all of that, we came up with our PT diagnosis as dizziness and imbalance with functional activities, secondary to a poor central nervous system compensation for vestibular hypofunction. So prognostic factors, the ones in black, I would consider those to be good prognostic factors. In red would be sort of the more negatives. So again, young, healthy, she had good family support. Her mom came with her to a few sessions, but certainly driving over an hour, having an $85 copay, and also having that 10 out of 10 for her initial rating is usually not a good prognostic indicator. But she was not taking any medication, so we didn't have to worry about that contributing to dizziness. That was good. But then she did have a pretty demanding schedule, being in college, and an athlete at that. So the goals we set for her, first goal is for self-management with an AGP. Second goal is to improve her DHI, so it's a subjective goal. And then the third goal would be for the DBA, more of an objective goal. And then lastly, it was to improve her balance when standing on the phone. So the last one was sort of an easier goal that we would hope she would reach earlier on. So as far as the plan, research suggests 6 to 8 weeks, the length of time that would be necessary. For this patient, we created the plan as 1 time a week for 10 weeks. So taking into consideration that finals were going to be coming up, Christmas break was coming up, she is driving a long way, all of those things going into it, I thought that maybe we should extend the plan a little bit to make sure, because I was kind of anticipating that there might be some missed sessions. We also had emphasized the AGP and patient education, so we actually provided her with an AGP at the initial eval, which included stage 1 visual vestibular exercises. So I have a picture of that I'll show you in a little bit, but it included smooth pursuit and VOR, so something to get her started there. So now that we've covered the diagnostic, evaluation, assessment portion, does anybody have questions about anything so far?
I heard you said, sorry, all of that packet of information, did that come from an MD or, okay.
Yes, from an ENT.
So why did you do 30 seconds for your VORs?
30 seconds. So there's not really any evidence that I found that actually backs doing the VOR as an assessment at all. As far as the homework that we gave her, we would do it for a minute because that was sort of based to her tolerance. So if she would go slowly, she could do it longer. But if she sped up, it would certainly make her dizzier. So it was kind of an arbitrary number, but it was one that we would come back to again so that we had something to compare. Does that answer your question?
Can you just repeat the question?
Oh, the question was why did you use 30 seconds when testing her response to VOR?
With the balance test, like the sharp and lumber, did she have like multiple tries to do them? I mean, I'm assuming. Because like, and then sometimes you might just have a bad trial or something like that.
So we tried to keep everything as objective as possible. So we would have a standard to come back to when we would reassess. So if she was able to get to 30 seconds on the first try, we would just cut her off and count that as good. If she didn't make it to 30 seconds, we would give her another try and then take the best of two. If she was maybe getting 28 and 30, then we would average them at 29. Does that make sense?
Yeah.
And the question was, how did we come up with the 30 seconds for the balance testing? Yes.
One more. As far as directional balance and balance, was there one direction that you tended to fall?
She just did a big side-to-side thing, but there was no one side or the other. It was just
Was any of the testing as far as that one?
there-
I mean, she failed in a lot of different things. I was just curious if there was a pattern to the way she tended to.
not that we saw, not that I remember seeing. No. The only thing she did have, her center of gravity was posterior, which I mentioned that a little bit again later, but she had a lot of knee hyperextension. So we did educate her a little bit to try and avoid that hyperextension. But as far as losing balance to one side or the other,
Posteriorly or anything.
no. It was more of a lateral movement than anterior posterior. So now this is the first visit post-evaluation. So it came back to the SOT because her results from the physician's office were pretty atypical, and I didn't really see the way it was administered. I felt that I wanted to administer that test myself. I thought that I could get more information that way, being able to actually see her responses, kind of what Dr. E was just saying, to kind of see what was actually happening to make her fail those different sections. And so when I administered it, she did not pass condition 2. So this is showing that she just had a little bit too much sway. She didn't lose her balance, but she had more movement than what would be considered normal for someone of her age and height. So the machine itself will compare her scores to an age and height reference norm. Also, conditions 5 and 6, you do see the word fall there. That just indicates that she did lose her balance. She didn't fall, she's in a harness, but it means she had to touch the wall or something. We had to stop the test there. And condition 5 and 6, both of them, but especially condition 5, are very typical for the vestibular patient to fail that. So this made a lot more sense than her original SOT. And she also, the composite score over there on the right is also abnormal, so she failed the test overall. So just some more information that we got from that. It's showing her center of gravity being posterior, which we talked about. Her strategy analysis between ankle and hip was not really anything super atypical. As far as sensory analysis, it did show that she was not utilizing her somatosensory system extremely well. She was about borderline as to what would be considered normal for someone of her age and height. But her vestibular system was far below the normal. And so just to bring us back, before I go into actual treatments, to keep in mind just evidence-based practice. So my clinical experience at this time is a little bit limited. Patient values for her was definitely golfing and that type of thing. Research evidence is very strong in support of habituation, adaptation, and compensation exercises. So the treatments that we do, even though some of them are, I just say static balance, we're also working on habituation at the same time throughout. So for the first 5 treatment sessions, it's just kind of showing the progression of static balance. So we would start with narrow base of support, move into half tandem, then move into full tandem as tolerated. We would also go from eyes open to eyes closed and include busy backgrounds, go from a firm surface to a foam, and then to that big squishy one, which is the one she had problems with. We would also include head turns and nods. And so it's definitely important that you only progress one part at a time, that you're not throwing too many things at a patient. So we did this throughout treatment and just progressively made things more difficult for her as we went along. The same thing was true for dynamic balance. So walking with a wide base of support would be sort of the easiest. We had her do backward walking, tandem walking, and tandem backward walking. We would also have her walking while doing VOR, or walking while doing smooth pursuit. So we would move something in front of her and have her follow it with her eyes. We would do head tilts. So that was this one I talked about earlier, as well as head diagonals, or even just randomly, I would call out right, left, up, down, and she would move her head. We would also do all of these. We would progress them from eyes open to eyes closed, and then from busy backgrounds to even busier backgrounds, and to we even did some object manipulation, having her pass a ball around her waist, and it was kind of a busy background on the ball, so having her follow that with her head, these types of things. We also worked on her postural controls because it was so poor during the evaluation. So this started off with just education because she had no idea that she was even doing anything wrong. We worked on some pelvic tilts in weight shifts on a Swiss ball. So this was to help her sort of dissociate the movement of her pelvis and trunk, so that if she is being perturbed on the lower body, that she would still be able to maintain her upper body, that trunk control there. Verbal cues that worked really well for her. We had her pretend that she was holding buckets of water that were filled to the brim. So try not to spill the buckets of water. That one worked really well for her. And then also providing just some tactile cues at the shoulder, just for that proprioceptive input, so that she could kind of feel what was going on and learn how to control that motion. So then we also did training in the Balance Master. So this is the same parameters or the same conditions that are done during the SOT. However, we're able to control the difficulty, so we can change the sensitivity of the floor and the walls. We can do them for longer times. But so we got her practicing in that as well. So here are the pictures of the HEP that we provided. So this is the stage 1 visual vestibular exercises. So part 1 and 2 is smooth pursuit, horizontal and vertical, and then 3, 4, and 5 are the VOR, horizontal, vertical, and head tilts. As far as standing balance, we had her doing these things at home as well. Standing in certain positions, moving her head, having her eyes closed. Every time she would come into the clinic, we would try to progress these so that she was going home with similar exercises, but just more challenging. So at visit number 6, I did a reevaluation. So everything on this slide was previously in red. So these are all the things that she did not pass or was abnormal originally. So you can see that she was able to improve most everything on this slide. However, with tandem walking backwards, she still had 1 loss of balance. So she went from having 6 losses to 1, so it was improved. But for an athlete of her age, she should be able to do that without any problem. So then we reassessed the VOR and the DBA. So again, we used that 30-second mark, which is arbitrary, but it's just a way to standardize it from one measurement to the next. This time, though, her baseline wasn't 0. She was actually already kind of on that thing. And she did increase symptoms a little bit with horizontal VOR. As far as the dynamic visual acuity, she had 21-25 this time, so it was a 6-line difference. So it improved by 1 line, but that's still pretty bad. It's far off from what would be considered normal. And the MDC for that is actually not established in any of the literature. So as far as the DGI, she was able to get a 24 out of 24 on that. But like I mentioned earlier, there's been a ceiling effect there, so I do wish I had used a different measure. As far as the DHI, she went from a 44 to a 32. So that did move her from the moderate category to the low category, but it wasn't within the MDC, so there's no way of knowing if that's like a true change or not. And then the SOT, I did administer that again. She passed all conditions with flying colors, went from an abnormal composite score to one that would be considered considered normal. So I did have a little emoji there, the one that like does the little thinking face. Because at this point, we're trying to think about whether we are actually going to continue therapy or not. So I'm kind of curious from you guys, hearing everything that we've done, if you think that we should discharge at this point or continue. Does anyone have any ideas?
I mean, how was her like functional tests? Was she back to doing what she wanted to do?
Right.
Or
So biggest mistake was that I did not ask the PSFS again. I think that would have been very helpful at this point. But we did talk about it, talked about the fact that she had definitely made improvements, but she wasn't all the way there. So I did want to also consider that she does have this high copay, she's traveling far. So she said that she would talk to her parents about it. She came back in and decided that she did want to continue with therapy. Do you have a question?
Did your patient follow the recommended number of times she was supposed to do the exercises?
She did. So the question was, did the patient, was she compliant with her home exercise program? And as far as I could tell, I believe that she was. I think that if she had not been, she probably wouldn't have made these gains. But she was very receptive to everything that we gave her.
That's specifically why I asked that question. Perhaps she only did it once or twice and she was young.
Yeah.
Maybe when you're my age and you have to do it 8 or 9 times a week, it's different.
Right. And it certainly is different. I chose this patient to present because she was atypical in the fact that she was young. Majority of vestibular patients we would see in this clinic were in the senior age group. So it definitely was different.
I'm young.
So for the next treatment sessions, I tried to really kind of up things, really challenge her. I also worked more towards in-task activities because I really hadn't been doing that much at this point. If we think back to the patient values, golf really was what she wanted to do. So we tried to do, I gave her the same exercises, but to do with her neck flexed. So it's more mimicking that position that you're in when you are golfing. Also had her doing some higher level things in the balance master. So we would have the floor moving with the foam on the floor, with the walls moving, doing VOR, sitting on a ball, just really trying to really challenge her system. And then the AGP also advanced that as well. So gave her some busy backgrounds to take home to use. She even had a shirt one time that had like its own busy background. So I was like, why don't you, even use some of your clothing as busy backgrounds. She had a Swiss ball at home too, so she started using that. And again, doing the gaze stabilization in different planes that mimic the position she would be in when she golfs. So now at visit 10, this was when we discharged. Did ask her about the PSFS again, which was 10 out of 10s for all of those. So everything she felt like she could do just the way that she did before. When retesting the VOR, she did not have any changes in dizziness there. She did still have a 5-line difference on her DBA. So did recommend her that she continue with her gaze stabilization exercises at home to try to see if we could continue improving that. But it clearly wasn't really having a functional effect on her anymore. So still didn't think that therapy was necessarily needed just for that. And her DHI did go down to 16, which is well within the MDC. So as far as goals, she met all of her goals except for the DBA. She improved by 2 lines. The goal was to improve by 3 lines. So we missed that one. And so things that I would do differently, I've kind of been mentioning them throughout, but definitely function. I should have worked into the golf much earlier. I also think that I should have challenged her much earlier. She was different than most patients that I saw, so I had to go a little bit slower with most patients, but she could handle most of the things we were doing, so I do feel that I could have probably gotten her out of there quicker if maybe I had challenged her earlier. Also anxiety, so there's a lot of strong evidence to show that anxiety and dizziness are related. And especially because her dizziness increased so much right at the start of college, which is a very stressful time. It's hard to really think that that's a coincidence. So I do wish that maybe we had talked about it at some point, but we didn't. And then as far as BPPV, I did not test for BPPV. At this point, I don't think that she had BPPV, but again, I would be curious if you guys have any opinions on if you think I should have tested it, or what your thoughts are on that. Anybody? I think Brian might have an opinion.
Just because of a lot of the positions like the golfing could have been a positional change too, moving forward to pick up the golf ball and everything. That's when she was experiencing it, or with the quick head turns. The fact though that a lot of your activities though she habituated with as well, if she would have had no change at all, it would have probably indicated something else, but she was improving, so that's a great
So
sign.
I agree. So I think that if we had hit that reassessment and she wasn't getting better, I probably would have tested for BPDB. And she was tested at the physician office, so she had been tested, but that's still something that I would have liked to do myself. So maybe if time allowed, or if I felt that it was more indicated, I would have. But at this point, I feel okay about the fact that we didn't. So my references. Does anyone have any questions?
Do we have some questions?
Yes, so in reevaluation, do you think there's a reason based on that one?
So I do, she said that she did not have, any motion sensitivity in the car, but I always kind of wondered, because she's going on such a long drive to get there, if maybe that could stir her up. But sometimes also in the clinic, just with the things we do, they don't necessarily leave at a zero. Like, we do kind of stir people up. We try our best to let them come back down and to never let symptoms get too high, but sometimes that's just how it goes. So we try to do those tests at the beginning. I don't remember if we did. I might have done it in the middle or at the end, which probably that's like a rookie mistake.
So the DGI was low level for her, looking back, is there a different outcome than you would have preferred?
Yes, so I think the FGA could have been good, the functional gait assessment. It includes some of the items that we actually looked at, like walking with eyes closed and walking heel to toe. So in reality, we did look at those items, we just didn't put it on an objective measure, but I think that would have been much better. Yes, sir.
How long ago did you do this evaluation?
So the referral came in on October 24th, which I think might have been our first day in that clinic. But she was seen about 1 or 2 weeks later. So very early in November was when she first came into the clinic.
Is there any follow-up that's scheduled for this clinic?
There's not.
Would you recommend that there should be?
I think as long as symptoms don't come back, I think that she's pretty much good to go. She did have the MRI and the CT, and all of that came back clear. We gave her exercises to continue. So I don't really see a need for follow-up unless her symptoms started to come back or there was some type of change in her status, in which case I would definitely recommend.
Did you counsel that patient to give you that feedback should it occur?
Honestly, I don't remember if I counseled her on that or not. I definitely know that I should have. I did with some patients, but typically when a patient does this well, I kind of was thinking, oh, you're good to go. So likely, I probably didn't counsel as much as I should have. But I can't. I honestly don't remember if I did or not.
As a senior citizen, I'm always interested in the age difference and how it relates. And I'm just kind of wondering if she slid back after 6 months, and whether someone might.
Right. So with senior citizens, unfortunately, the vestibular system, it kind of acts kind of like the rest of the body in the fact that it just doesn't function as well as you age. So just the way that if you stop going to the gym and you kind of lose your muscle mass, if you stop working your vestibular system, it will also start to kind of poop out on you a little bit. So certainly that's a reason that senior citizens, I think, are more affected. And a lot of these exercises, I think, would be very beneficial for a lot of senior citizens.
They are.
Good. That's good.
Question for you. On the initial eval, did she have issues with smooth pursuit?
On the initial, so we did not test smooth pursuit.
I know, but it came back, I know that you did on the, that came through the packet and stuff. I
Yes.
don't recall if there was.
No, she had during the optokinetic testing, which was like, so if you think about a bunch of trees outside your window going by, so it's like smooth pursuit saccade, smooth pursuit saccade. She did have an abnormal velocity gain on the right, but as far as just the smooth pursuit itself, it was normal.
So my question for you is, why did you not see pursuit?
Well, so I called it smooth pursuit, but I probably shouldn't have, because what we would do is move the board back and forth, and we didn't have her only moving her eyes, we actually had her moving her head and her eyes. So it was kind of actually just stimulating that system by getting the head movement. Yeah.
And then as far as the VR exercises, were you doing just times 1, so you do times 2, so what type of exercise?
We gave her VOR times 1 to start, and then progressed her into the VOR times 2.